in the second part, we're going to start now also looking at immediate implants. And what we'll look at is really the literature and try and get an understanding of how we manage these. And I hope I can show you that the principles of managing immediate cases will be much the same as what we talked about. In other words, to establish a stable architecture of bone, to have an adequate soft tissue dimension, obviously the correct positioning of our implants, to have components which maximize the volume of tissues, other words, concave or narrow components, and all the other things that we discussed, the appropriate contours of a restoration and so on. So when we look at the literature, much of the literature has told us that we see soft tissue changes in bone after extraction of teeth. Schropp's work has shown quite dramatic changes in the width of the ridge in extraction sites, and we know that this is the case. We also know that if we place implants into extraction sockets, providing that the labial bone is present, that we can see fill of the bone in that jumping distance. A number of studies have shown this, and that distance can fill even 2 or more millimeters of space. But unfortunately, these studies don't really talk about what happens with the buccal volume, and once the space fills, we lose buccal volume. Of course, if there's a dehiscence, then Schropp also showed that that bone would not form, and you would end up with a dehiscence on the implant too. Hence the reason to graft in those situations. Another study which has been much quoted, unfortunately, and probably I think has been a bit misleading. But let's have a look. It's from Arujo's work and Linda's group, where they did extraction sites in dogs, placed implants, and they've demonstrated that we lost bone, and placing an implant into an extraction socket, after a number of weeks we lost more bone, and that the conclusions were that the implant failed to preserve any hard tissue dimensions and that they causes bundle bone, and that it would be a problem and that you would lose it. But if we look carefully at the diagram even, and particularly if we look at the study design, we can see that perhaps there were some flaws in the design of the study which influenced the results. In fact, if you look at the fact that there is a flap raised and that the implant size is almost as wide as the ridge, you can see it shining through the thin buccal bone, and they're using a human-sized implant in a dog mandible, and also to recognize that the mandible of a dog may not be the same as a human maxilla in the aesthetic zone. Of course, we know that even the bone in our human patient in the mandible is different, of different origin and different behavior than maxillary bone, and we should always remember that. And lastly, that we see that the flap is raised, which obviously compromises the results. So, in fact, the design of this study was pretty poor, and I'd say you would almost guarantee that they would get these results with a study design like this. So we have to be very careful what the literature shows. This is not a reflection of clinical practice of this type, and clearly there are loads of mistakes that we've already talked about with some of our experience in clinical studies. And finally, let's remember that animal studies are pretty low on the order of evidence compared to human data and clinical experience. We see other literature that tells us that we need to create bone volume labial to the implant for stability, and that we need to have this big buttress of bone on the facial aspect of our implants. Is that reality, though? I don't think it is. I think we will see that bone will flatten on the facial of our implants. Certainly when we revisit sites that we've had implants in for some time, it's not unusual to see even dehiscences of the implants labially in perfectly healthy and stable implant situations. So I'm not sure that the bone on the labial is that stable or that important, but we do know we need to have support for our soft tissues, of course. And much of this data has been based on the study by Spray, which is often quoted in papers from the previous paper that I showed you even. And they claimed that we need 2 millimeters of bone. But if you read the study carefully, you'll see that actually the study was looking at the bone changes or volume changes between placement and uncovering. And that's not really what we're looking at. We need to know what's the difference between uncovering and function later on. In other words, what happens after the placement of our final restoration. So again, this study really doesn't give us any useful data, and so I don't think it has that much value. Similarly, we hear a lot about connective tissue these days, and of course I, as many others, agree that this is very important, but let's be clear what the literature shows. And the Bianchi There's a paper that's been often quoted as well. And even their conclusions, they make the conclusion that the connective tissue graft is a predictable procedure that was what was considered to be a sure system to reach an excellent functional and harmonious aesthetic restoration. It's a pretty strong claim to make, isn't it? And but if we look at the paper in detail, well, what's very interesting is that we see, first of all, that most of the cases they treated were indeed posterior teeth. That's very interesting. And what's interesting to me is that, well, if I was writing a paper and publishing a case to present to support my case, would I put my best case or my worst case in that paper? Well, I would put my best case. And if we look at this, it's very interesting that in the paper that's presented, the case they've chosen is a mandibular second premolar, hardly a tooth of aesthetic importance. And if we look critically at the case, and remember they said it was a predictable procedure, it was a sure system, we see that on the right side, the extraction site with the implant placed, and they take a wad of connective tissue which they pack under the flap or under the tissues on the sides, and then in the third picture in the middle you see that the flap seems to have dehisced. If I look at that, it looks pretty much like the graft has been lost. If we compare the volume buccolingually of the top right picture with the bottom middle picture, we see that there's no comparison. There's a significant loss of buccal volume, and the end result, if that's considered to be an excellent aesthetic outcome, then I think that that needs some revision, because I don't consider that to be an excellent aesthetic outcome at all. So we have to really be a little bit skeptical about what we see in the literature. It doesn't always actually say what it says, and unfortunately, because the literature tends to be so one-dimensional, it only overlooks at one aspect, and the story is not just about one particular thing. It's many different things working together in optimum way to manage our cases. So let me just outline for you the key steps, if you like, to optimize the soft tissue aesthetics with implants in the aesthetic zone. And we can see them listed here. There are 9 things, really. That if we can extrude our teeth with orthodontic extrusion prior to extraction, that might be a good idea. It's been suggested by many. I would say that that's really not a useful protocol for single teeth. It's good for multiple teeth and for groups of teeth, and doesn't really give us a great deal of benefit from a single tooth point of view. I think this is much easier to manage surgically. Secondly, to use a bovine anorganic bone mineral for better stability and contours, as you can see. Thirdly, to position our implant in the correct position. Fourthly, to thicken our labial soft tissues for the correct dimensions of the biologic seal at the time of transmucosal connection, to under contour and have our flat components on the facial aspect particularly. There is some discussion that the materials that we use might be of importance. Maybe zirconia, aluminum, titanium are better choices than gold, feldspathic, porcelain and acrylic. Certainly we know that we can't get any tissue adherence to any of those materials in the latter group, whereas in the certainly in the first group we see a greater biocompatibility, and some tissue adherence has been demonstrated by some workers. It's been suggested to avoid disconnection, so we try and place our abutment early. I'm not sure that that really is such an important thing, but certainly it's a good idea, developing our provisional contours. And what an important thing it is to make sure that we control our cement excess when we finally cement our crowns. I think putting a retraction cord in is mandatory if we're going to cement anything, because just to prevent any cement entering into that area around the implant. These are what I consider to be the key ones out of those 9. There's probably 1, 2, 3, 4, 5, 6 key ones that we really need to focus on, much like we said at the beginning. So let's look at the management of a single tooth case, an immediate extraction case. And this is a typical one. It's a case which could be quite challenging. There's a previous crown. There's been a root fracture here. And we can see that we've managed to catch the tooth in time. It's been referred quickly, and we had the opportunity to consider immediate replacement. And we can, first of all, understand that today there is more of a consensus about this approach. And if we look at the literature, even from Arujo, they've gone back and looked at these things after criticism from from colleagues, obviously, a number of papers that have shown that, well, really, the conclusions are that if we place a bone substitute material into that space, such as anorganic bovine bone mineral, that maintains the volume, plus that we do a connective tissue graft of some kind, this was beneficial in limiting the resorption process. And although much of this data is in dog models, certainly our clinical experience would back this up. And let me show you how we would manage these cases. So here we extract the tooth. You can see the extraction socket. You see on the left side the tooth before extraction. Here's your extraction socket. Carefully debriding, managing to get all the granulation tissues out, de-epithelializing the internal aspect of the tissue, and ensuring with magnification and with just feeling with our instruments that we have an intact buccal plate. This is important, otherwise we wouldn't place the implant immediately. So placing our implant according to protocols today, which is towards the palatal aspect, of course going into the palatal wall, apical, about 1/3 from the apex. Many people have taught this. I'm sure that it's a standard, well understood protocol. Leaving a space of at least 2 millimeters or around 2 millimeters on the facial aspect of our implant. And we're going to pack a biomaterial into that, and we place our bone substitute and firmly condense that into that space. Not so firm as to fracture the buccal wall, remember, but firmly, not loosely packed into that area. And you can see that the situation should look something like this by the time we've finished with our cover screw in place. Then we can remove our cover screw, place our healing abutment, and then after de-epithelializing the internal aspect of our tissues, we can take a connective tissue graft and we can place that between the healing abutment and the labral tissues, and we can even tunnel upwards a little bit superosseous in the facial area if we need to stabilize that tissue better. A couple of small microsutures in there. This patient's wearing a little temporary denture, and you can see the healing after a little while. And then if we move on, we can just show you a quick video of how we take the connective tissue. Not the same case, obviously, but just showing that we do this from a single incision in the palate, as described by a number of people now, and using a little SM59 type double-sided blade. We make a superficial dissection of the tissue palatally, about a millimeter or so below the tissues, and then we take a deeper cut down to the level of bone, as you can see here, and we then dissect down above the bone and take a wedge of connective tissue out from the palate in this way, typically going mesial to the palatal root of the first molar and forwards, or if we have a tuberosity, that's even better because the quality of the tissue tends to be better there. Sometimes in the palate we get quite a degree of fat in the tissue, which is it's less useful for augmentation, tends not to give as good results. But generally we can get sufficient, certainly for a single tooth case, you can easily get sufficient volume of tissue from the palate for a case of this kind. And you can see the video here just as we're just dissecting this very carefully and just getting quite a nice chunk of tissue out of the palate in this particular case here. And here it goes. We'll just watch it. There we go. So, and we can see that we can close that very easily with sutures to seal that up. And you may get a little bit of sloughing, but it tends not to be particularly uncomfortable for the patient. So after a couple of months, and going back to our case, we tend not to do that many immediate loadings, simply because often the stability of the implant is not always ideal, and there's always a risk of facial loading of the implant. But if you have an excellent stability, then of course you can make the option to place your abutment straight away, and we can prepare an abutment to place. But in this case, we waited just a couple of months for initial stabilization. Take a narrow impression coping, we design the abutment in the lab to the ideal contours, and then we can try that in the mouth and alter it as we've discussed before. And you can see it's very much like a crown preparation, supporting the tissues proximally, but under contoured facially. We place a provisional crown, develop the final contours, and then we would take an impression of the abutment in situ with a retraction cord, just like a crown impression, and have the final crown made to fit onto the abutment. And you can see here the 1-year follow-up of that patient. And what's interesting, we can look at the 2-year follow-up, and you can see that really that we've seen no remodeling of the bone. And in fact, the bone, even on the right side, looks like it's actually moved coronally onto the abutment. And this is interesting. It shows very nicely the concave nature of that abutment and the very excellent stability of the soft tissues in not such an easy case. And so you can understand the same principles, creating this, really respecting the biology and trying to work with that prior to doing the work. So let's look at a case which is a little bit more challenging. So we have a patient here with a high lip line and high aesthetic demands as well, pretty lady. And she has a couple of not so nice crowns. These are actually provisionals. She's been referred to us by her dentist. She's had a root fracture of the upper left maxillary incisor, and we have some problems here. If we look closely at the radiograph, we can see the distal bone is missing a little bit coronally. It's not so easy to see, but and we have some inflammation. If we look at the palatal view, you can see inflammation of that distal papilla on the incisor. We have prominent root architecture, we have thin tissue, which you can see the shine through of the dark root, and we have already quite prominent and dominant central incisors. We also have lateral incisors which are rather short looking, so there's not a very good harmony of the gingival margins. So let's have a look at the case and just examine the situation here. We have a high lip line. We have a high lip line with the high aesthetic demands, challenging. We have central incisors dominant with prominent roots. We have thin tissue which shines through the underlying dark root. We have gingival margins which are disharmonious, and probably need to do a little bit of recontouring on the laterals as well to create more harmony. We have a root fracture of the maxillary left central incisor with an inflamed distal papilla and bone loss, and that's a compromise for us, and we know that that will influence the outcome. We look at the papilla now. That is not going to be what we will achieve with the final outcome. The patient needs to know that, of course. We have disharmonious crown clinical crown length, and we've lost this bone, as we've already said. So this is how the patient looks. When we remove the provisionals, we can see that it's been patched up and sort of held together, but it's in pretty bad shape. So we extract the tooth carefully. First of all, examine, have we got an intact buccal plate? Yes, we have. We can consider an immediate approach and try and preserve things. You see the granulation tissue in the area of the distal where the fracture was, and of course this is going to cause some compromise. So we want to be careful not to disturb too much the papilla. We want to try and maintain as much volume as we can here. So following the same protocols, and this is the important thing, the principles are the same. We create our adequate stable bone architecture first, placing our implant correctly, leaving the space, filling with the biomaterial, supporting our bone, deepithelialization, placing our soft tissue graft, narrow healing abutment, augmenting the soft tissues there. We placed our biomaterial with some amelogenin or emdogain to try and enhance the bone reconstruction. Now, after a week with the provisional, this is the provisional that was sent by the dentist or given to me by the dentist. We tidied this up and just replaced this with a nicer provisional, as you can see. And we've also carried out some recontouring of the soft tissues after checking the biologic width to find out where the bone is. And we found that we could just do a simple gingivoplasty and give us a little bit a nicer outcome here. You can see after healing that we've got a more sort of appropriate, better aesthetic outcome. Please notice the stability of that soft tissue around the implant restoration, where we have a high risk of recession, and if there is recession then we have a compromised case, and this is very important that we are able to control this. So this is the final outcome in the same protocols. Having placed the final abutment early, allowed provisional to sculpt healing to occur, then taking an impression of the crown and the abutment in situ and making our two crowns there. You can see the 1-year follow-up. And what's interesting to note is a very nice stable labial tissues, contrary to what the literature says. Of course, the distal papilla is compromised, as we expected it to be. But if we look at the radiograph, we can see our bone graft on the mesial aspect of the lateral incisor and the level of regeneration that we seem to be getting there. It's only 1 year after the follow-up. We tend to see a maturation occurs after 2 or 3 years, and hopefully we may see some improvement in the papilla too if the bone reestablishes itself. But let's see, we have to be realistic and understand that there are maybe some limitations in a case like this. But it's a nice outcome nevertheless. So as you can see, on these cases, we're really talking a lot of times about combinations of bone and soft tissue augmentation in order to manage these cases correctly. And this is pretty much a standard today in most cases. Sometimes we may have adequate bone in a heel ridge to hold the implant, and then we just need to do an augmentation of the soft tissue to create our biologic seal and the components of our peri-implant mucosal complex that we need to have the adequate dimension. But often we need to do a little bit of both. So let's have a look at an alternative approach. When we can't do an immediate implant, of course, you have some things on the slide here. This has been published by me in a number of articles. I think actually there's an article in the European Journal of Aesthetic Dentistry here, and the second one talking about some of these different proposed approaches. In this lecture, I'm not really going to talk about socket seal and socket preservation because that's a whole other subject. But you can look at the reference here, and it talks about this quite nicely. I have to admit, it's not something that we like to do that often. There are some cases where we like to do it. I generally prefer to do an early, a delayed implant placement approach, an early delayed approach, which we'll talk about. So flapless surgery can be done where we've got certain parameters. Intact labial bone is one of the main ones, really, that we can do an immediate placement. If we lose that labial bone, then we've really got to come back, or if we have a significant infection, we've really got to come back and do it later. So in our delayed approach, we've got the options that wait 6 weeks for soft tissue closure, and then we can do our augmentation, or we can do a socket preservation technique, which some people prefer. My preference is probably is not the socket preservation. I think that really just takes more time, and I'd rather just wait 6 weeks. And let's show you how we work. So here's a case. Again, challenging case, thin tissue biotype, thin scalloping, fractured root with a fragment that's already extruding labally. And we can see that we have also some evidence of some bone loss on the radiograph. And when we do the same things as before, we carefully extract the components, we evaluate, and we see that there's no labial bone in this case, and we can see very thin labial tissues in the slide on the right. So we allow for healing. We place a Rochette bridge or a denture as is appropriate. In this case, a Rochette bridge is possible. Wait for 6 weeks of healing. You can see we have a nice healing now, and just like in the video that we saw earlier, we're very similar sort of defect. We treat this the same, maintaining the papillae, the blood supply to the papillae, the sulcular incision, and just leaving the papilla in place, as you can see here, with the U shape going palatally in the area of the actual where the implant's going to go, and just leaving mesial and distal papillas in place with blood supply from the palate, which seems to be the important blood supply. And then you can see placement of the implant in the correct position. It's an older design of implant, but still the principles remain the same. And as you can see, positioning this correctly, harvesting our little bone to cover the threads, and then our biomaterial over this, and then our wall membranes. So basically the same principles as we used before, narrow implant components, the roll flap to enhance the soft tissue volume on the buccal, as you can see in this case. In the second slide here, you see the thickness of buccal support there, and what we've created on that situation there. Place the Rochette back, allow things to heal, and you can see how things progress. Radiograph, and you can see nice healing of the bone in the radiograph. And at 3 months, we are now ready to uncover and start our process of making our abutment. So narrow abutment, the same deal as we've already mentioned, under contouring on the labial. Again, this is probably going deeper than we'd go today. This is an older case, but we would take our margin a little bit more coronal today and place our final crown. This is the 2-year follow-up of the restoration, the final placement, and this is now the 5-year follow-up. And you can see how stable the bone levels are, really no loss of bone, and that we have a very stable aesthetic outcome. There's a little bit of rolling of the tissues because our patient was being rather more aggressive with the toothbrush than they should be, but we've helped them with that, and that should heal up, no problem at all. Another case, much more difficult case, lower incisor, a tricky area to handle because of the smallness of the teeth. And you can see a significant defect here. And really I want to show that these same principles apply. So same thing, wait 6 weeks, place our implant, our augmentation. First of all, to augment the bone, do a closed healing. This is a defect that was both lingual and buccal, and we've closed up, complete flap. First stage to rebuild the bone. Then we come back after 6 months or so. We're going to split thickness dissection, augment now the soft tissues, place our transmucosal component, and you can see how we've done that very nicely, increased our volume, and we can see now are placing our abutment. As before, same principles, provisional, then final crown, and this is now the crown at 1 year. I'm sorry, there's a little overlay of my text there, but that's at 1 year, and this is now at 3 years. And you can see here a 3-year stability of that labial tissue is excellent and a really good outcome. And radiographically we see how nicely that's doing. Another case, even more complex perhaps. Now we see a patient with a hopeless tooth that's rather been treated rather more aggressively than we would really suggest. It's been some in my mind, ridiculous efforts to try and keep this tooth, but anyway, here we are. So, problems. We've got significant infection, we've got a tooth that's failing, we have a big aesthetic problem, a large lot of tissue missing, we have bone loss on the distal aspect with already a compromised papilla, triangular teeth, mesially inclined lateral, all these things that compromise our outcome. So what do? We extract, we allow things to heal. We know we're going to lose bone on the lateral, papilla on the lateral because we've already missing bone, so we have a compromise there. So the best we can do is to try and build this and make the patient aware that the distal papilla will be slightly deficient. So we allow soft tissue healing to occur for 6 weeks, and then we open our flap. As you can see, we preserve the papilla. In this case, normally we'd do a crestal incision in a case like this, but because we're going to try and preserve as much tissue as because of the bone loss, and if you look on the mesial aspect of the lateral incisor, you can see the bone is missing. We've got facial bone loss, we've got distal bone loss, and we've got palatal bone loss. So in this case, we place our implant, and the design of implant in this case is not important. We're just trying some different designs out. I don't think I'd use this one today. But anyway, we place in this patient a scallop design, and the principles, however, are the same. We augment the site. We also use a little bit of amelogenin or emdogain to try and gain some bone attachment or attachment on the tooth. You see the graft both from the labial and from the palatal aspect, advancing the flap to close, allow 6 months of healing. After 6 months, we open with a split thickness dissection, and this time we're going to we did a split thickness palatally and labially, and we're going to augment significantly the soft tissue volume, because whilst we have now created bone, we still have inadequate soft tissue. And remember, if the soft tissue is inadequate, then the bone will remodel to create space for soft tissue. So you need to have more soft tissue. And you can see us with a connective tissue graft, a little bit of rotation of some of the keratinized mucosa to help us. And this is the result at placement of the final crown. And we allow for maturation now to occur. You see the rebound of tissues on the papillae, and what's notable is the stability of the labial tissues at 18 months, and let's have a look at that after 5 years, and you can see that we have a really stable result. Deficient distal papilla, yes, but we knew that because of the bone loss, but it's still, and also the rotation position of the rotated position of the lateral, but nevertheless, pretty decent result considering the complexity of the case. So let me just summarize again these key steps then for optimizing the soft tissue aesthetics of implants in the aesthetic zone. As we said, we can use orthodontic extrusion, but I think this is limited for single units. I don't think it has much use. It just makes the treatment more complex and doesn't really help us biologically, because you're not really increasing the dimensions of the tissue in the way that you need to. In other words, you've still got to do the surgery. For bone maintenance and volume, of course, the inorganic bone mineral, the correct position on the implant, the soft tissue thickness that we've discussed, the right shape of our components, the materials may play an important role, early placement of the abutment, developing the soft tissue contours and taking our final impression of the abutment in situ and controlling our cement excess. And as we've said before, these are probably the key ones, these 6.